It's pretty easy. Right? How hard can it be? They go and they pull the clot out. Now, the trick with surgery is that when it first was developed in the 80s and even in the 70s, the associated mortality was really high, and the surgeons didn't like that. The problem was that the people who were selected to go to surgery had all had cardiac arrest at least once, right? So of course they have high mortality rate. And so what the data show are if you actually take a patient who's unstable and they don't have a filtering, which we can talk about later, but we're not going to talk about now, of course their mortality is high, right? If you take patients that have already had cardiac arrest once, they tend not to do so well, right? But if you get people to the operating room before they're unstable, then the mortality is actually 14%. It's still high, but you know, we're talking about unstable PEs here, right? So if we can get them when they're intermediate risk, then surgery is not a bad option. But if you wait until they've already coded, they're not going to do as well. So the question that we asked about 10 years ago was, what do we do with all that? All that data I just showed you. How do you figure it all out, right? There's a lot of new treatments. There's catheters, there's suction devices, there's surgery, there's ECMO, there's heparin, there's thrombolysis, there's mini thrombolysis, there's all that stuff. So how do we figure it out? And so what we invented was this thing called a PERT team. Has anybody ever heard of this? Yeah. So this has now become pretty much the standard of care. And when a patient comes in with a severe PE, we have one phone number that we call, activate this team. The team is made up of emergency physicians like me, pulmonary critical care, interventional cardiology, interventional radiology, surgeons, ECMO. And as soon as the call comes in, it comes in from, say, our unit. We identify the PE, we activate the team, and we immediately have a conference. We thought we were quite clever in 2012 because we had a video conference, which in 2012 was actually pretty cool, right? We used technology that probably doesn't even exist anymore, but now we do a Zoom call or a Teams meeting or whatever, right? So for better or for worse, COVID accelerated our ability to do what we were doing before and made it more mainstream. But now we can sit on our phones and all get on a conference together with a multidisciplinary team, and everyone hears about the case. We can look at the scan, and everyone votes. And I will tell you that interventional cardiologists and pulmonologists do not vote the same. Right? They are very different people. Right?
Resident cardiology.
That's right. You know, the hematologists are like, well, we can do this. And the radiologists, the interventional radiologists are like, well, I got this catheter. Right? And the surgeons are like, I got this knife. You know, and then they fight it out. Right? And the emergency physicians are like, I don't care, just get them out of my ER. Right? So this is the way the team works. And it's pretty cool. And what we found was, in fact, if you bring everybody together, you can't, it's difficult to read, but you can see that there was a slight increase in the use of treatments. But once you had a team, that use of treatments went up. So we were able to get people to more treatment faster. Most of the time, people still just got anticoagulation alone. So on the one hand, we were facilitating people getting to treatment, but on the other hand, we weren't doing it for everybody. Right? We were making a thoughtful decision about 15 to 17% of people who had intermediate risk PE who said, yeah, we should do a catheter, or we should send them to surgery, or we should do something more than just anticoagulation. But 80% of people still just got anticoagulation, right? Which is, I think, probably about right for this population of patients, right? And over time, people started to look at how these teams were working and what was happening. One study, which I'm not going to show you, showed that among trainees, actually, among residents and medical students, they felt like the presence of this team was really good for their education. Because they got to hear these discussions, they got to hear the debate between the pulmonologists and the emergency physicians and the cardiologists, hear all of the different strategies. all together in some meeting that takes 15 minutes, and they thought it was really good for their training. But as it turns out, it was also good for patients, because if you look at the time before these teams existed to the time after these teams exist, the mortality goes down, the length of stay in the hospital goes down, the amount of mechanical ventilation goes down, the time to therapeutic anticoagulation goes down, and overall mortality in 30 days goes down. So you bring together a team of experts who fight it out amongst themselves, and you improve patient care. And this has been shown at multiple hospitals, to the point where the European Society of Cardiology has now actually included using these teams in their guidelines. Okay. This is now what we do. So in this case, we had our 58-year-old guy, remember, right? He had his intermediate risk PE. We activated our team. The team got on its call, had a discussion, fought it out, and ultimately decided to take the patients to the cath lab for a suction thrombectomy, because those devices work really well when the clot's right in the middle of the heart and right in the middle of the pulmonary arteries. So if you remember his CT scan, the clot was in the saddle, there was lots of proximal pulmonary artery clot. That's easy to get at with a suction device. And so sucked it out and it goes like that. Okay? All right. How are we doing? Perfect. We have 15 minutes for our